I cordially invite Professor Jitangi Vanigasinghe and Professor Saraja Vijayasekara to chair the symposium. Over to you.
Very good afternoon to all of you. So together with Professor Saraja Vijayasekara, we will be chairing this interesting session on pediatric autoimmune disorders and demyelination. So our first speaker is Professor Sylvia Tenenbaum. She's a chair and Professor of Neurological Sciences and Division Chief of Multiple Sclerosis at the University of Vermont, Larner College of Medicine in Burlington, Vermont. Professor Tenenbaum actually is in charge of the Neuroimmunology Clinic and the program at the Department of Neurology of the Paediatric Hospital in Buenos Aires, Argentina. So without further ado, over to you, Professor Tenenbaum.
Thank you for your nice introduction. Well, hello everyone. It's a great pleasure for me to be able to participate in this great session. My talk is going to cover the differential diagnosis of autoimmune central nervous diseases in children. I'm Sylvia Tenenbaum, a pediatric neurologist from Buenos Aires, Argentina. Well, these are my disclosures, but really they are not related to this talk. It's very interesting to see the way that all the central nervous system neuroinflammatory syndromes have been expanding their spectrum because new autoantibodies have increased our possibility to get or to reach an accurate diagnosis. It's always interesting to remark that there is an overlapping on the clinical presentation among all these diseases and syndromes. And for that reason, diagnostic criteria for these disorders need to be regularly updated. Now we are going to compare the three main autoimmune diseases, starting with multiple sclerosis, which really is a multifactorial autoimmune disease with a complex interaction of genetic risk factors, as environmental triggers, but really we don't have a defined autoantibody. Compare with two diseases that have a real autoantibody that's completely identified, the AQP4 positive NMOSD, and the MOGAD, the myelin oligodendrocyte glycoprotein associated disease. If we start with the most important clinical syndromes, we can start it with the optic nerve involvement. And the main differential diagnosis compare these three diseases. For multiple sclerosis, usually the findings are very subtle, just a very short and very subtle brightness in one of two of the optic nerves, but it is more important to look for the typical brain lesions on FLAIR or T2 on the brain MRI. It's different for AQP4 positive NMOSD, when you can identify a longitudinal extensive involvement of the optic nerve with progression to the optic chiasma. For MOGAD is as well a longitudinal extended involvement, usually bilateral and very frequently with a progression to the anterior part of the optic nerve involvement the optic disc. You can see that on fundoscopy and you can see on the MRI. And this interesting diagram by Dutra in 2018, you can compare the findings between these two diseases. For MS, usually short, focal, unilateral, infrequent optic disc edema with a variable contrast enhancement. And on visual evoked potentials, commonly you will find a delayed latency, but infrequent decibel decreased in the amplitude. Conversely, in MOSD AQP4 IgG antibodies, there is longitudinal extensive, unio-bilateral, more common posterior, involving the optic chiasma, and developing in the visual evoked potentials a decreased amplitude. And for MOGAD, often longitudinally, more common anterior, with an optic disc swelling, optic chiasma is usually spared, but very frequently you have a perineuretic and orbital fat enhancement. And as well as the NMOSD, on the visual evoked potential, you may identify a decreased amplitude. There are a series of mimickers of differential diagnosis that have a different mechanism of action, and we are going to compare these findings through the red flags by clinical cases, pediatric clinical cases. In this case, this adolescent have a severe recurrent headaches. On fundoscopy, there was papilledema, but there was absent of the spontaneous venous pulsations. You can see then the MRI. From the clinical point of view, all those were red flags. If you see the MRI, you can see the distended optic nerve sheets on the axial and on the coronal view, flattening of the posterior sclera, and tortuosity of the optic nerves. And you can find anticella turcica. All of those are red flags for inflammatory mechanism, but are very indicative of an intracranial hypertension. So you should look for the etiology of the intracranial hypertension, that may be thrombosis of venous, brain central venous, or pachymeningitis, or midline tumor. Another case with acute or subacute vision loss, blurred vision, central scotoma, but with no pain with eye movements. And that's a real red flag. Then you see the fundoscopy, there is optic swelling, okay, what else? A macular star. So if the fundoscopy you find a macular star is representing intraretinal lipid deposits, this is another diagnosis. And you can see on the MRI the enhancement of the posterior part of the retina corresponding to this macular star, which is representative of a neuroretinitis. Neuroretinitis may be caused by infectious diseases. Bartonella henselae is the most frequent, Bartonella quintana less frequent as the infectious etiology, but you should look for Coxsackie virus B, histoplasmosis, toxoplasmosis, even syphilis. Another case with subacute vision loss, but you have a red eye. A red eye with clinical signs of intraocular inflammation, such as orbital pain, photophobia, tearing, are all red flags for a neuro or autoimmune process. On fundoscopy, you see hyperemia of the optic disc, and you can identify serous retinal detachment on the fundoscopy, and you can see the detachment on the MRI as well. In the CSF, if there is inflammatory signs with lymphocytic pleocytosis, you have the diagnosis of an uveitis associated to the Vogt-Koyanagi-Arada syndrome. These patients need a very hard rescue therapy, acute anti-inflammatory therapy, in order to improve the vision of these cases and to start immunosuppression, of course. Subacute vision loss in a patient with short head, no pain with eye movements, those are red flags. We can see an hyperintense lesion involving bilateral optic nerves, but particularly left one. Nevertheless, the patient received acute rescue treatment, high dose, intravenous methylprednisolone, plasma exchange, and there were no improvement after this therapy. So if you combine no pain with eye movements, no improvement after rescue treatment, you go back to the images and you see that the optic nerve is more infiltrative than inflammatory. And you can see a very well thickening extended to the optic chiasma. So we decided to perform a biopsy of this lesion. In addition, the antecedents of this girl is that during the 2 or 4 months, she was suffering from polydipsia and polyuria, and that's an indication of an hypothalamic dysfunction, where the biopsy disclosed an optic nerve and chiasmal germinoma. Move now to the spinal cord involvement and the differential diagnosis between MS, AQP4, IgG positive NMOSD, and MOGAD. For MS, usually it is a short spinal cord involvement with or without enhancement, but on the axial view, you can see this more lateral or posterior, the position of the lesion. For AQP4 NMOSD is a longitudinal extensive spinal cord involvement, and on the axial view you can see that it involves the central and peripheral part of the spinal cord, so central gray matter and white matter as well. And for MOGAD, usually there are multiple sites of the spinal cord involved. One of those should be longitudinal extensive, usually involving the conus medullaris with this very clear periconus enhancement, just a pencil-like way. On the axial view, you can see that the involvement is of the central gray matter with the H sign there. There are as well different characteristics that are briefly put in this diagram by Dutra. MS were usually short, less than 3 segments, partial, peripheral, spinal cord involvement, more cervical than thoracic, exceptional the involvement of the conus, in different patterns of enhancement. For AQP4, longitudinal extensive, more than 3 segments. Consider that initially the first event may be a short spinal cord involvement. Usually central cord, but involvement gray and white matter, cervical and upper thoracic segments that may extend to the dorsal medulla. Frequent enhancement with variable patterns. And for MOGAD, longitudinal extensive as well, central cord involvement with the H sign, more frequent lower thoracic segments, lumbar segments, and the conus frequently involved. And the frequent pencil-like linear periconus enhancement you have already seen. As well, there is a list of differential diagnoses with different mechanisms, infectious, vascular, functional, included paraparesis. But let's see some clinical cases. The girl developed acute onset of a flaccid weakness with a predominant involvement of the upper limbs, symmetric or asymmetric. And for the point of view of an acute flaccid myelitis involving the upper limbs, that's a red flag for an autoimmune inflammatory process. Frequently, these patients have an antecedent of upper respiratory infections, and you perform the MRI and identify the longitudinal extensive involvement of the spinal cord with the anterior and central involvement. But look at the axial view, and you can see the involvement of the anterior spinal cord lesion with anterior gray matter involvement. It's interesting and it's very important to look for cluster of this kind of acute flaccid myelitis in your region. In Argentina, there was a cluster in 2016, and was an infectious myelitis due to enterovirus D68. Another clinical case, rapid onset of weakness, less than 4 hours, with a transient neck or back pain. From the clinical point of view, those are red flags. You can identify the temporal correlation with suspected triggers, maybe a back fall, a trivial fall, or extended neck, an episode of very severe coughing, years of riding. You look for the findings in the MRI, and you see there this lineal hyperintense lesion involving the anterior part of the spinal cord. In this case, it's more in segmental, in this part of the spinal cord hyperintensity, and on the axial view, you can identify the anterior gray matter involvement. The spinal cord infarction with this typical hyperintense lesion with a vascular distribution give you the key that this is a vascular mechanism. The pathognomonic finding is to look for the associated radiological changes in the posterior aspect of the vertebral body opposed to the spinal cord lesion. This is a fibrocartilaginous embolism. Clinical phenotype, this is a patient with walking difficulties after a fall at school 4 months before given a carry to our consultation. So 4 months of evolution of a progressive walking difficulties. No functional improvement after receiving rescue therapy. All of those are red flags. And you look for the MRIs, and you can see a fusiform thoracic cord expansion on STEER, on T2, and with gadolinium, the central nodule enhancement, maybe central, maybe lateralized, You look for that on the axial view. When this patient was biopsied and was on spinal cord astrocytoma. Finally, looking for the typical lesions in brain and brainstem involvement, compare MS, AQP4, and MOGAD. In MS, you have the small, very typical, well-defined white matter lesions in the periventricular location of subcortical or juxtacortical involvement, usually with black holes on T1, and very small lesions involving brainstem and cerebellar peduncles. Some will enhance, some others will not, and this is dissemination in time. In AQP4 and MOSD, the brain MRI may be normal or may show this dot-like lesion, very small, but what is pathognomonic is the brightness surrounding the third and fourth ventricle. For MOGAD, these are very large lesions, usually with enhancement, maybe with this aspect of pseudoleukodystrophy pattern. And the brainstem lesion or brainstem involvement is as well very tumefactive. Comparing the three diseases, for MS is a discrete ovoid lesion, supratentorial, typical hyperintense periventricular, juxtacortical or cortical, and for the infratentorial involvement, brainstem and cerebellar peduncles. Frequently, you will find T1 hypointense lesions, variable contrast, and if you have the susceptibility weighted images identifying central venous signs, and PRL, which is paramagnetic rim lesions, you have the diagnosis of MS. For NMOSD, periventricular location, periaqueductal, area postrema, thalamus, and hypothalamus, maybe large confluent hemispheric white matter involvement, or normal brain MRI. For MOGAD, there are large, tumefactive, with poorly demarcated borders. That's the ADM phenotype, maybe the leukodystrophy-like pattern. And for the autoimmune encephalitis phenotype, you have the cortical gray matter lesions. Variable enhancement and central vein sign may be identified, but not PRL. There is a list of mimickers. We are going to see some clinical examples. Here, the background is an acute or subacute onset in a patient, in a child or adolescent with persistent febrile syndrome, systemic symptoms, meningeal signs. All those are red flags and are indications of central nervous infection that should be ruled out. You look for the brain MRI images, and you have the typical patterns for the herpes simplex 1 encephalitis, for toxoplasmosis, or these signs of infectious vasculitis typical of the Streptococcus pneumoniae associated meningoencephalitis. Other cases with this restriction pattern in diffusion and ADC that we can see in a very young boy with EBV encephalitis, and the typical enhancement involving the basal brain, you should rule out tuberculosis, meningoencephalitis. There are a number of infection-triggered encephalopathic syndromes that have typical MRI findings. In this case, you have the bithalamic involvement, symmetric, typical for ANE, acute necrotizing encephalopathy, triggered by influenza A or SARS-CoV-2 as well. Here you have the typical images of the MERS, is the mild encephalitis with reversible splenial lesions, may be triggered by influenza A as well, but have been described in GFAP astrocytopathy. And here is a very nice picture of what is the restriction diffusion in this brain MRI comparing diffusion and ADC. This is the alert at acute leukoencephalopathy with restricted diffusion triggered by herpes virus 6, adenovirus, influenza A, but as well in dengue. Other clinical case with acute or subacute encephalopathy, severe and persistent headache, difficulties visual acuity or the visual field. Focal neurological deficits may be identified, but the context of these patients is an acute arterial hypertension or blood pressure fluctuations. All those are red flags and can be observed in adult patients in the preeclampsia or in situation of sepsis or renal disease. And the typical MRI is going to give you the diagnosis of PRES, which is the posterior reversible encephalopathy syndrome, with a completely different mechanism of action. Encephalopathy with confusion, cognitive slowing, even seizures, but preceded by recurrent and severe headaches, including vomiting, visual problems, and the patients usually refer a sudden hearing loss. Those are red flags. You should perform the MRI, and the MRI is very high yield. It's going to give you the diagnosis. On the axial view of FLAIR, you can see the corpus callosum with a number of lesions, better identified on the sagittal views, FLAIR and T1. And you can see the central involvement of the corpus callosum with the snowballs. In T1, you see the punched out central holes, which are showing you that there is a vasculopathy involved. Then you see the diffusion, and on diffusion weighted images, you identify a string of pearls involving the posterior limb of the internal capsule on the right. Then you only have to complete with the fluorescent angiography, identifying the brow, branch retinal artery occlusion that you can see here. It was an adolescent with the Susak syndrome, and it demands a completely different treatment. So usually you have to consider and rule out differential diagnosis, always. May I suggest two publications, recent publications. One is the 2023, where the international panel published the MOGAT proposed diagnostic criteria, and there is a supplemental table with very well-defined differential diagnosis for optic nerve involvement, spinal cord, or brain. And the following year, with Professor Andrew Solomon, we published differential diagnosis of MS in pediatric and late-onset population, with very clear tables comparing all the differential diagnoses that should be considered. In the paper by U.S. Solomon and myself, you can see the 4 topographies with the list of differential diagnoses that should be considered. So my final remarks is the detailed clinical history, context, antecedents are key to give you a diagnostic orientation. Neurological exam and the clinical phenotyping, both of them is going to guide the diagnostic studies to be performed. MRI, look for imaging pattern, distribution, morphology, and the behavior of the contrast enhancement. And always consider and rule out clinical and neuroimaging red flags. Thank you so much for your attention, and I hope that you have enjoyed the presentation. Good evening for all of you.
Thank you, Professor Tenenbaum, for that very interesting lecture in differential diagnosis of pediatric demyelinating diseases I think we have time for 1 or 2 questions. It's the question time, the audience.
May I ask a question? It's actually about radiological findings in demyelinating disorders, particularly ADEM. In our practice, it's very difficult to obtain an MRI in the acute phase. So sometimes there is a delay, and we tend to treat the patient. So what's your take about the occurrence and disappearance of the MRI changes? How much of it is affected by use of medication when we treat them before we obtain the MRI?
Thank you for your question. In Latin America, we have the same difficulty of not having very quick an MRI to get the appropriate diagnosis. And the children with acute encephalopathy and multifocal deficits, after having ruling out an infectious disorder, you should start treatment. But I would recommend to preserve CSF and serum samples before starting treatment, just for sending for MOGAD antibodies and have the possibility of the correct diagnosis later on. You put the patients on high-dose intravenous methylprednisolone. You may decide if you are going to use gamma globulin, and it's a very severe picture of clinical involvement. You are allowed to start plasma exchange or therapeutic plasma exchange. Usually the lesions in ADM cleaned or disappear after 2 or 3 months after treatment. So if you have the MRI 2 or 3 weeks after the acute rescue therapy, you still could have the opportunity to identify the pattern of lesions that confirm your presumed diagnosis of ADM. So always perform the MRI, complete MRI, orbital, brain, and spinal cord in order to identify all the topographies that were involved in the acute event of neuroinflammation. And when you have the opportunity, send the CSF and serum samples to identify the autoantibody involved in the neuroimmunological process.
No question.
Hi Sylvia, it's Owen Flanagan here. How are you? It's early start for you over there. I had a quick question, just wondering, MRI of the orbits for children, with suspected MOG, or do you always order an MRI of the orbits in your patients?
Owen, how are you? I could identify your voice. Thank you for asking. I always request to perform an orbital MRI in my patients. It doesn't delay too much the study. So orbital are performed in all children because it's very usual, with and without contrast enhancement. Because it's key to give us the diagnosis, for example, of MOG antibody involved in an ADM case in a young kid. So it's very useful. I always request to perform orbital MRI. It's very important.
And then one other thing, I was just thinking, do you think our mindset should change a little bit sometimes with these conditions, that they should be considered more urgent, in terms of getting that MRI, or a patient, presenting to the hospital, that we should try to make it available because it can really help clarify the diagnosis and the treatment plan. And sometimes I think, with stroke and things, we think about these, urgent MRIs, but with other conditions, we sometimes tend to, we'll wait. But some of the MOG children in particular can get very sick very quickly. So the MRI can really help guide you in what's going on. Yeah.
Absolutely, you are right. But in Latin America and in other parts of the world, maybe there is not available an MRI machine in the same institution where the patient is admitted. But always, it's very important to perform the MRI before starting the acute rescue therapy. The contrast enhancement are key to give you the orientation of the appropriate diagnosis for the 3 diseases that we were comparing with, but for additional with other mechanisms, other disorders. But I insist, if you don't have an available machine, you are going to lose the contrast enhancement part of the imaging. But it's very important as well to perform the MRI after receiving the acute therapy. It's as important to perform the MRI as it is to start giving the anti-inflammatory therapy to these children. Thank you for asking.
Okay. In the absence of any further questions, let us thank Professor Sylvia Tenenbaum for that excellent talk and the very interesting discussion. Thank you very much.
It's my pleasure to introduce Professor Tanuja Chitnis, Professor of Neurology, Harvard Medical School. Prof. Chitnis is the inaugural chief of the Division of Neuroimmunology at Mass General Brigham. She's a professor of neurology and holds the Cindy Larson Chugg Endowed Chair in Neurology at the Brigham and Women's Hospital. So over to you, Professor Chitnis, to talk to us on the advances and challenges in pediatric MS therapies.
Well, thank you very much to the Selectrums committee for the invitation to speak. It's really an honor. And I'm joining you from snowy Boston, where it is much colder than in your location. So I wish I was there with you. So I'm going to speak about some of the work in treatment in pediatric multiple sclerosis. And before I start, I think we, as pediatric MS practitioners, know that this is a highly inflammatory disease. Children with MS have 2 to 3 times as many relapses as adults do. And as well, there is a higher T2 lesion volume on pediatric MS MRIs compared to adults typically. And we also see similarly a higher rate of accrual of new lesions and also now very high levels of neurofilament light chain through serum and plasma assays. So I think that's been well established. And what's also now been well established is that despite some of the initial good signs of pediatric MS, that some of these children might recover from relapses well early on or be slower to accrue disability, at any given age, they will have more disability than a typical adult onset patient. And this is a study from our group looking at outcomes at the age of 50. And many of these young patients or young onset patients are not working at the age of 50 and have not been able to form many of those connections that are needed in young adulthood going into older adulthood. So it is really tantamount to treat these children with effective therapies. And this study has also demonstrated that, it asked how do patients with multiple sclerosis accumulate disability? And adult MS patients accumulate disability largely through PIRA or progression independent of relapses, whereas it was clear that pediatric MS patients accrue disability largely through RAW or relapse associated worsening. So it is, again, tantamount to treat these patients and prevent relapses to prevent further disability. So, we've brought this acronym, Bring on the Heat, and I think given the highly inflammatory nature of pediatric multiple sclerosis, it is important to think about highly effective therapies. And over the past 20 years that I've been practicing, I've seen the evolution of using lower efficacy therapies now to the very transformative use of higher efficacy therapies. And so this is what we do recommend is high efficacy therapies for pediatric multiple sclerosis. But of course, there must be a risk-benefit balance. And the risks of these therapies include infections of many sorts, pneumonia, sinusitis, reduced immunity, and also drug-specific adverse events. Whereas the benefits can be many, including relapse control, prevention of disability accrual, and improved quality of life. So this is a tricky balance to strike, not only in adult MS patients, but especially in children, where we are just learning about the effectiveness and side effects of highly effective therapies. So in the United States, we have over 20 disease-modifying therapies available for adult patients, and this is largely through many clinical trials, and this has accrued over the years. And it is fortunate that we have many options available now. Now, this is not the case in pediatric multiple sclerosis, and in 2012, we convened a meeting to discuss how to start pediatric trials in order to get some of these therapies approved for use in children. And this was a meeting that was convened with regulatory agencies, as well as MS societies, patient groups, and other networks. And here we decided on deciding on outcome measures for pediatric trials, as well as including things like cognitive measures in our studies. So this led to the start of pediatric MS clinical trials, and this is where we stand now in terms of the trials that have been started and completed in green, and those that are still ongoing in black. So we've made a great deal of progress. However, one of the challenges is that we don't have as many treatments approved for children, especially in the United States. Only one is approved, Gilenya, whereas in the EU, there are several that have been approved based on the clinical trial data. So there's a difference in regulatory approvals, but there is actually not a difference in use of these treatments, and there is much off-label use of many of these therapies ongoing in the United States, especially the use of highly effective therapies. And I'm also going to apologize for my voice. I'm just getting over a cold, so hopefully my voice is clear enough. So one of the first studies that was done looking at these highly effective therapies was the Paradigm study, which compared fingolimod or Gilenya to what was then the standard of care, beta interferon 1A, and this was a randomized double-blind placebo, actually not placebo, but a controlled trial where we compared the two drugs to one another, and it was clear that there was a benefit of fingolimod compared to beta interferon 1A. 86% of the children treated with fingolimod remained relapse-free, compared to 39% on beta interferon 1A over the 2-year period. So this was a clear benefit, and it also demonstrated an improvement on quality of life, as reported by both children and their parents. So this was also very nice to see and match the clinical results. It was a major advance, and this drug was approved in the United States and many world regions, and led to the first highly effective therapy for pediatric multiple sclerosis. The next trial that was completed was in using dimethyl fumarate, and this compared DMF to beta interferon 1A. Here, the main outcome was radiologic, and it demonstrated a reduction in new T2 lesions, as well as annualized relapse rate in pediatric multiple sclerosis. And this drug was approved in the EU for use in children. The TerraKid study compared teriflunomide or Aubagio to placebo, and this is given the effectiveness, the moderate effectiveness of teriflunomide. It was only deemed to be feasible to compare this one to placebo, but the outcome was time to new relapse. So then every child would start on treatment if they did have an event. Later on, it was a combined outcome of time to new relapse and MRI activity, which was found to be statistically significant, with the teriflunomide arm performing better. However, when using time to new relapse alone, it was not statistically significant. And there was a commensurate reduction in MRI lesion load, both on T2 lesions as well as new gadolinium-enhancing lesions. So the natalizumab study was a PK and PD study, which looked at dosing in younger and older patients. A phase 2 or 3 study was not performed. However, there have been large series from especially the Italian group, where they looked at natalizumab across a large cohort of pediatric MS patients, 101 patients, and demonstrated relapse-free periods over 2 years, which was quite impressive, as well as no new MRI activity. However, one of the challenges, of course, with natalizumab is that many patients can be JC virus antibody positive, and this requires monitoring throughout the treatment course. Alemtuzumab is a treatment that was studied in a small cohort of pediatric MS patients. This was looking at a number of new or enlarging T2 lesions over an untreated period compared to a treated period, and it stopped because of side effects in adult patients. There is a small report in Multiple Sclerosis Journal. Rituximab has been a mainstay of pediatric MS treatment for many years, and this is based on a number of open label studies, which have been summarized in this publication in Multiple Sclerosis Journal. And here you can see that the numbers of patients range from 14 to 56, and overall the treatment was found to be effective in preventing and reducing relapses as well as new MRI lesions. So we have a lot of open label data as well as safety data accruing for rituximab. However, one of the major gaps was B-cell therapy clinical trials. So given these studies so far that were performed, something called International Pediatric MS Study Group came together again and discussed how to further enhance these clinical trials for children with multiple sclerosis, and how to make sure that they were performed without placebos. So we recommended no placebo studies be performed. We also recommended considering MRI as a primary outcome measure. And we also recommended studies in which all children would receive highly effective therapies, which led to the advent of something called non-inferiority studies. So one of the first to complete in this area of non-inferiority studies was an evaluation of ocrelizumab compared to fingolimod in pediatric MS patients, and this is the Operetta 3 study. This was presented at ECTRIMS by Brenda Banwell in September. So this is a double-blind, double-dummy, two-arm study with a flexible duration, and the goal was to compare ocrelizumab IV or a fingolimod placebo to fingolimod orally with an ocrelizumab placebo. So it was quite an involved study involving both pills and IV forms of drug, but it was rigorously performed. There were dual assessors, both a treating investigator and an EDSS or examining investigator, and patients were randomized 1-to-1 to these two treatments. And there's an ongoing extension arm and safety follow-up. Now, the primary endpoint is non-inferiority of ocrelizumab compared to fingolimod, and this was deemed to be a non-inferiority margin of 3. So there's a lot of statistics involved in this type of analysis, but basically to demonstrate without a shadow of a doubt that ocrelizumab performed better or as well as fingolimod on relapse rates. There's also a non-inferiority outcome of T2 lesion accrual, and also looking at the T1 gadolinium enhancing lesion accrual and annualized relapse rates, and looking here at superiority. Of course, other safety endpoints included adverse events and laboratory results. So this is the baseline demographics of the patients. They were well matched, and in the fingolimod and ocrelizumab arm, typically in our pediatric studies, the mean age is 15. It's a lower EDSS than most adult studies, 1.5. However, the majority of patients have a gadolinium enhancing lesion on baseline MRI, which is fairly typical of this inflammatory disease course. And the results show that ocrelizumab was non-inferior to fingolimod in controlling relapses. And in fact, there was a 48% risk reduction in annualized relapse rate in the ocrelizumab arm compared to fingolimod. And it did meet this non-inferiority margin of 3, demonstrating significance on the primary endpoint. There was a strong suppression of relapses in the ocrelizumab arm. In this diagram, you can see to the range of 10% or 0.1 compared to the fingolimod arm, which the relapse rates rose to about 0.2. And overall, the severity of relapses was moderate in the ocrelizumab arm, with some variation in the fingolimod arm. And the majority of relapses in both arms recovered completely. So in terms of MRI outcomes, ocrelizumab significantly reduced new or enlarging T2 lesions compared to fingolimod. And again, this met the primary endpoints of both non-inferiority as well as a superiority of about 48% risk reduction in MRI endpoints. And adverse events were slightly more frequent in the ocrelizumab arm, largely driven by infusion reactions, but also infections, including nasopharyngitis and influenza, were slightly more common in the ocrelizumab arm. Serious infections were similar in the two arms. So overall, the study demonstrated that ocrelizumab was non-inferior to fingolimod on annualized relapse rate, with a risk reduction of about 50% compared to fingolimod, and it was superior on several MRI outcomes. There were similar rates of serious adverse events, but slightly more upper respiratory tract infections in the ocrelizumab arm, but overall a good tolerability. And we'll get results from the open label extension in the next tranche of data. So another study that's ongoing that's examining B-cell therapy in pediatric MS patients is a study called NEOS, and this is comparing the efficacy and safety of ofatumumab with siponimod and fingolimod. So this is a parallel assignment 3-arm study, which is quite impressive. Again, double-blind, and the outcome is non-inferiority. So this is, again, all patients will receive what we think are highly effective drugs in the pediatric MS population. And there will be similar outcomes, annualized relapse rates, and also MRI outcomes. So this is a young patient who I think you'll recognize from Sylvia's very nice overview as having lesions that are quite typical of multiple sclerosis. And here you can see these periventricular ovoid type of lesions that are quite pathognomonic, lesions in the corpus callosum. And we evaluated her. She had all of the features of multiple sclerosis and was ruled out for some of the common mimics, including MOGAD and NMOSD. Her CSF was quite typical, and she had 5 oligoclonal bands and met the McDonald 2025 criteria for multiple sclerosis. So now, given all that we've talked about, which treatment would you choose? And these are probably the top 3 choices that I would put forward. However, one of them was knocked out immediately because she was JC virus antibody positive. She also had a congenital atrioseptal defect, which was spontaneously repaired, so we had concerns about starting fingolimod. So our next choice, and what we did do, was we started rituximab or B-cell therapy, given both its efficacy as well as just this was the best choice for this young patient. So 2 years later, she was doing well. She had no new relapses or MRI lesions for 2 years. She was doing well from the MS standpoint. However, her IgG had decreased to 400 milligrams per deciliter. Normal in our range is over 800. And she had recurrent sinus infections requiring multiple rounds of antibiotics. We had started to replete her as well with IVIG, and she developed aseptic meningitis. And during this period of time, she also required sinus surgery because of these recurrent sinus infections. So this is fairly typical for patients who we start on B-cell therapy. Some do have these more serious side effects and others don't. But we have seen a fair share of young patients with severe upper respiratory and some with lower respiratory tract infections, including recurrent pneumonias. So 3 to 5 years later, we said, well, we need to pare down the immunotherapy, and we don't have many choices in her case. And so we decided to start on dimethyl fumarate. We are monitoring with serial MRIs, neurofilament light chains levels in her serum, and as well as neurological exams. And at age 20, she's doing well from the MS standpoint with no new relapses. And her infection status has been fairly good as well and fairly well controlled. So I think this case raises a couple of questions, and just in terms of B-cell therapy, it is very exciting that we hopefully will have more options. However, it does come with some challenges, and one of the challenges is the increased risk of infections. This includes COVID, and this was a series from our large US network database where we found that COVID hospitalizations were associated with B-cell therapies in children treated for multiple sclerosis and other demyelinating diseases. As well, we looked at a series in our cohorts from MGH and found that B-cell therapies were, as we had noticed in our clinical case, were associated with severe respiratory infections, sinus infections, and other outpatient infections. So again, this does come with some challenges, and we do need to think about monitoring very carefully for infections as well as for immunoglobulin levels. So some of the challenges that we have identified and talked about now, risk of infection, as well as an inexperienced immune system. And I think we have to, as we're applying these stronger therapies to children, we have to keep in mind that they have limited prior immunity. They've only maybe been able to accrue an immunological memory up till the age of 14 or 15, and then we started them on immunosuppressive therapies, and they don't have that experience, as that immunological or infection experience as others do. There also may be vaccine series interruptions and also increased exposures through school and college and other situations where they're exposed to a large number of patients or of other people. So, thinking about how to mitigate this risk of infections, I think we caution our patients about infection risks, an inexperienced immune system, Some of my approaches now are to consider natalizumab or fingolimod or these anti-trafficking agents to increase immunity for the short term, and then consider B-cell therapy later on if they break through. Vaccine series interruptions. I think this is a discussion with a pediatrician as well as an infectious diseases expert to complete vaccine series prior to starting immunotherapy, continuing annual flu vaccines, COVID vaccines, and also to consider pneumovax and Shingrix, particularly in patients who are immunosuppressed with B-cell therapy for the case of pneumovax, and Shingrix, especially for patients who are on S1P modulators. Increased exposures in school and college. This is critical to complete the meningitis vaccine series. And I realize that in Sri Lanka, this is going to be different in terms of the vaccines that you will recommend. However, this should be tailored to each region. And low immunoglobulin levels, this is something that we're doing on a regular basis, constantly monitoring these levels and maybe establishing a cutoff where we start IVIG replacement and possibly increase the dosing intervals of B-cell therapy. So given the exciting advent of B-cell therapy now becoming more widely available and data becoming more widely available, I think we need to think about these cautions. So in terms of our approach for treating pediatric MS patients is to discuss and make decisions with parents as well as the particularly teenager, weigh the risks and benefits of various treatments very carefully, and discuss these, particularly the infection risks. We do recommend strongly to start on higher efficacy treatment with close monitoring, and then consider infection risk and mitigation strategies with vaccines and other approaches. And then monitor carefully with MRIs every 6 months at treatment start, and then annually as our practice. Another alternative or adjunct is also checking serum neurofilament light chain levels, and this could also help to monitor for new lesions. So I think some of the open questions in the management of pediatric multiple sclerosis is it best to start with anti-cell trafficking agents like natalizumab or fingolimod, and then use B-cell depleting therapy, possibly for a limited period of time. And there are now studies that are looking at using B-cell therapy for some limited period of time and then paring down or de-escalating or even stopping treatment and looking at the immune response to determine if relapses may still occur. So it is possible. Hopefully we will find that this does deplete the bad cells, and maybe this will be an approach that we will maybe take in the future as we have more data. Can we de-escalate therapy after B-cell depleting therapy is another open question, and hopefully our next studies will answer these. And can we develop more targeted therapeutics for MS in general, especially pediatric MS, given the nature of this disease in young patients who have a limited immunity? So I'd like to end by thanking all of the groups that work on clinical trials in pediatric multiple sclerosis, the International Pediatric MS Study Group, the U.S. Network of Pediatric MS Centers that I'm part of, as well as my group at the Massachusetts General Hospital. And thank you for your attention.
Thank you very much, Professor Tanuja Chitnis, for that very interesting talk on paradigm of treatment in pediatric MS. We have some time for questions from the audience. Please.
Hi, Tanuja, it's Owen Flanagan here. How are you? Early start
Great,
over there.
how are you?
I'm good. I just had a quick question. Do you do any immune monitoring before starting treatments to see if you can predict who might get infections like T or B cell subsets, or have you looked into any of that, or is there any evidence of anything that could help predict? Because it seems a bit variable which patients will develop kind of more severe hypogammaglobulinemia and many will do fine. So I was wondering if there's any way to predict and then choose your treatment accordingly.
That's a great question, and we haven't been doing that routinely. but we are having discussions with our ID experts about this. And I think coming up with the right panel, it could be looking at plasma cell proportions in the blood as well as B cell functionality. So I think that's a great suggestion and something that we will start to do in the future. One of the things that I want to explore, and maybe others have data around this, is IgA levels, and particularly since we do see a lot of sinusitis and mucosal immunity issues, IgA levels might be associated with these, and I'm starting a study to look at this.
Thank you very much for that wonderful lecture. May I ask a similar question to that was just asked? We don't see MS very much in this part, particularly in kids. So what's your take about how aggressive MS would be in kids in different parts, particularly in our part of the world? Because we don't see many patients. So how aggressive should we really be? And what's the data on their long-term outcome?
Yeah, so I think in Asia in general, it is pediatric MS, and MS is more rare. I think some of the discussions around treatments and the risk of infection applies to children with MOGAD and NMOSD, which may be more common in your area. But I think that generally across different world regions, pediatric MS behaves very similarly and is more inflammatory across different world regions that have reported in. So I would expect it to be similar in your region as well. In the rare cases that you have had, I'll ask you if they have behaved in this way.
Not actually. They have not behaved very badly. At least the patients that I have seen.
Yes, well, that's interesting. That's good, and maybe that's something to look at and compare. I'd be interested in looking at this with you.
Hi, Tanuja. This is Peter Hartung. How are you?
Very good. Nice to see you, Peter.
I just wonder, and I had to leave the room for some minutes. I may have missed it. Did you talk about or discuss EBV-targeted therapies for pediatric patients, or maybe CAR T cells?
Yeah, I did not, and that's obviously a very interesting and hot topic. We are actually starting one of the EBV vaccine trials, which will target very early MS, so RIS patients, CIS patients, not pediatric multiple sclerosis per se, but I have several patients, at least one or two, who have very early pediatric multiple sclerosis, are now turning 18 and are interested in EBV targeting therapies. I think, probably the question that you're getting at is pediatric MS, you are probably acquiring EBV infection in these adolescent years. It's very early on, and is there a chance to boost the immunity to EBV and maybe stop the disease early on? So I think this is a really exciting time, and we'll learn a lot from these first vaccine studies.
Thank you.
So, in the absence of any further questions, let us thank Professor Chitnis for that wonderful lecture and also the interesting discussion. Thank you very much.
Thank you.